Greetings from Fourrts. We welcome all the participants to this international webinar on dietary interventions in preventing diabetic kidney disease and postponing kidney replacement therapy. On behalf of Fourrts, we thank today's moderator, Dr.Pratim Sengupta, for his valuable time. We also digitally welcome and thank today's international speakers from Bucharest, Romania, Dr.Liliana Garneata and Dr.Carmen-Antonia Mocanu to India for accepting our invitation to talk today. Fourrts is in the pharma industry for the past 45 years, following the motto of innovating for good health. We are the pioneer and leader in nephroprotection with brands like Nephrosave, Nephrosave Foot, Nephrosave Keto, and Sodisave. Our Keto Alpha analog brand Nephrosave Keto is the most affordable brand in the market, which is available as both tablet as well as sachet. At present, we are exporting our products to over 50 countries around the globe. I am happy to welcome our director, Dr. Gayatri Veeramani Jayaraman, to inaugurate and host this webinar. Dr. Gayatri Veeramani Jayaraman is an American board certified physician and nephrologist. She is an attending physician in Mass General Brigham Hospital System. She has completed her fellowship training in nephrology at Harvard Medical School. She has served as clinical assistant professor of medicine at Weill Cornell Medical College. With this, I hand over the session to Dr. Gayatri for the further proceedings.
Thank you everyone for being here today. We actually have a very interesting group of doctors who have registered today. Among us, we have nephrologists, diabetologists, cardiologists, urologists, internal medicine doctors, and other specialties. So thank you everyone for being here on a Friday afternoon. We also have very accomplished panelists, and for this we're very grateful. I think we can have a wonderful discussion on a very important topic today. It's my pleasure to introduce Dr. Pratim Sengupta as our moderator today. Dr. Pratim Sengupta is the president of Kidney Care Society and managing director of Nephrocare. He's an advisor to the government of India's National Organ and Tissue Transplant Organization. He's also director of nephrology and renal transplantation at ILS Group of Hospitals. Thank you, Dr. Gupta, for being here today. As our main speaker today, we have Dr. Liliana Garneata, who really needs no introduction. She's very well known as an expert in the field of renal nutrition. A lot of interesting research on keto alpha analogs and nutrition is coming out of Europe, and she's been spearheading a lot of the research and initiatives. Dr. Garneata is head of the Department of Nephrology at Davila Teaching Hospital in Romania. She's published over 100 papers and serves as Associate Director of BNC Nephrology. She's also Director of the Romanian Renal Registry. Thank you, Dr. Garneata, for being here with us today. We also have Dr. Carmen-Antonia Mocanu with us here today, who's doing a lot of interesting work with Dr. Garneata and serves as Assistant Professor in the Department of Internal Medicine and Nephrology at Davila Teaching Hospital of Nephrology. With that brief introduction, in the interest of time, I hand over to Dr. Pratim Sengupta. Thank you.
So, thank you, Dr. Gayatri, and all the accomplished speakers and those like Liliana Garneata, who has done so many path-breaking research in the field of conservative nephrology. And obviously, Antino is a very accomplished nephrologist, associate professor from Mocanu. So, today the topic on which we are going to throw some light, that is diabetic kidney disease, which is very relevant in this country, having India being the largest diabetic patients. And in terms of the diabetic nephropathy, this subset is concerned, is a huge burden in this country. And we all know that the behavior of the all diabetic patient does not become same. And diabetic nephropathy is one of the most dreadest complication we can think about in the life of a diabetic. And in terms of their prognosis, in terms of their comorbid conditions, in terms of their resource utilizations for the healthcare, for their survival, mortality and morbidity risk everywhere has a huge impact. So prevention on diabetic nephropathy is a main area of interest over the years. So I'm sure Dr. Liliana Garneata will throw some specific light how by modulating or intervening for the nutrition, we can prevent diabetic nephropathy and also deter the initiation of progression. So over to Dr. Liliana, please. We'll love to learn from you. And obviously, those who are here, whatever the questions, whatever things are coming, I'll give it due justice to all the questions in a scheduled time. For the interest of time, let us start it. and see what we can learn from them.
Thank you very much for this invitation. I'm deeply honored to participate in this meeting together with the Indian colleagues, especially today, after we have celebrated yesterday the World Kidney Day, but actually we are talking about the World Kidney Week. So we are still celebrating these days the kidney health. So I have to congratulate all the Indian colleagues who are involved in the kidney care. I'm going to take the idea of the dietary intervention to prevent diabetic kidney disease and to postpone eventually the kidney replacement therapy. So when I am discussing about the dietary intervention, I'm going to focus on the low protein diet. Of course, that's not just the low protein diet. In diabetic kidney disease, we are discussing also about the low carb diet. We are discussing also about the low salt diet, but the discussion today will be focused on the low protein diet. The low protein diets are known for about 1 century to be useful in postponing renal replacement therapy, mainly through a better metabolic control. The low protein diet is demonstrated to ameliorate the nitrogen balance, the metabolic acidosis, and the mineral bone disorders. Although there are data published back in 1964, after the results of the modification of diet in renal disease study, which reported conflicting results, the interest for the low protein diet decreased considerably, both in patients and in healthcare professionals. More recent, there are research data to support the possibility to reduce the rate of decline in kidney function with low protein diets and to optimize the blood pressure control and to reduce proteinuria. And both the proteinuria level and the blood pressure control are known to interfere with the rate of decline in kidney function. There is also the possibility to ameliorate the insulin resistance through a low protein diet, which is of paramount importance in patients with diabetic kidney disease. Now, talking about the protein restriction, in spirit of this lecture, I'm going to use the term of conventional low protein diet for a protein intake of 0.6 gram per kilo per day. And we are discussing about mixed proteins, both vegetables and vegetarian and animal proteins. Then there is the keto supplemented low protein diet, which is 0.6 gram, again, mixed proteins per kilo per day, plus keto analogs, 1 tablet per 10 kilo of dry body weight. And there is also the very low protein diet with 0.3, 0.4 gram per kilo per day, supplemented either with essential amino acids or with keto analogs of the amino acids, 1 tablet for 5 kilos of dry body weight per day, the one called SVLPD. In the past years, there are a lot of data to support the superiority of vegetarian and vegan low protein diets in improving metabolic disturbances and in optimizing blood pressure control in patients with chronic kidney disease. Nevertheless, the low protein diet should have an individualized approach. There is no size fitting all. In each patient, we have to take the individual habits of the patient and the individual clinical aspect, and then to go further to an individualized, again, low protein diet. But again, for the spirit of this lecture, we are going to use the LPD 4.6, the SVLPD 4.3 gram per kilo per day, supplemented with keto analogs. Why should we focus on diabetic kidney disease? And Professor Sengupta already told us that in India in particular, diabetic kidney disease is a huge problem in nephrology. Here are some data from the United States renal data system. And I have mentioned here in yellow the situation of Romania. Here is the incidence of end-stage kidney disease in 2019, and one can see that we had 127 patients per million population starting end-stage kidney, kidney replacement therapy in 2019. And we can see again that we are close to the European mean, which is 129. But when we look down, and we have no data from, there are no data in the USRDS for India, but there are some states here in Asia, and one can see Malaysia here and Thailand here and Taiwan here with almost double incidence as compared to the European mean. So chronic kidney disease, and in particular end-stage kidney disease, is a huge problem, especially here in Asia. But when we look at the percentage of patients who started kidney replacement therapy because of diabetic kidney disease, we are here in Romania with just 13% of patients with diabetic kidney disease. I don't think that the situation in Romania is so good as depicted here, but still these are the data, and I can further explain after this lecture. But again, if we look down here for Malaysia, for example, almost 60% of the patients started kidney replacement therapy because of diabetes. And that's the situation as well in Singapore. That's the situation of 46% in Taiwan, and so on. So it seems that particularly in Asian countries, and also in Mexico, if you look down here, there is particularly important to look at the problem of diabetic kidney disease. Now, is it possible to prevent the diabetic kidney disease in a diabetic patient? If we take the natural history of diabetic kidney disease, it is probably relevant to show that in the beginning of kidney impairment in the diabetes, there is overfiltration. The glomerular filtration rate is higher than normal, and it takes years then for the structural changes to appear. And once the structural change appeared in the kidney, then the GFR started to go down till the end-stage kidney disease. But nevertheless, we have to remember that in the first stage, we are discussing about very beautiful GFR, a GFR even higher than normal in the subjects matched for gender, for age, and so on. Then, if we look at the rate of progression of chronic kidney disease, here is a study on a large sample size, and one can see what's happening, that overall the percentage of patients going to end-stage kidney disease, 18% in general. But if we take only the patients with diabetes mellitus, the rate of decline in kidney function is much higher. Could we interfere with diabetic kidney disease? Could it be cured? Could it be reversed? The answer is unfortunately no. Could the progression be stopped forever? The answer is unfortunately again no. But could we reduce the rate of decline in kidney function? And fortunately, the answer is yes. And this is probably the main message for the World Kidney Day this year. How could we prevent or slow down progression? And here is the glomerulus. And one can see that we can use the angiotensin converting enzyme inhibitors or the sartans in order to make vasodilation preferentially on the efferent arteriola. And this way, we are reducing the intraglomerular pressure, thus reducing the rate of glomerular sclerosis. Then, if we take a low sodium diet, again, we are decreasing the intraglomerular pressure and the rate of progression of kidney function. More recently, we are discussing about the SGLT2 inhibitors, which are acting again to reduce the intraglomerular pressure. And this is a very promising pathway, again, to slow down progression in both diabetic kidney disease and in a non-diabetic CKD. But if we know that if we take a normal or high protein diet, there will be vasodilation of the afferent arteriola, and there will be an increased intraglomerular pressure. Conversely, if we come with the protein restriction, with a low protein diet, there will be vasoconstriction, on the afferent arteriola, and there will be, again, a reduction in the intraglomerular pressure and in the rate of decline. In other words, if we take a low protein diet, a low sodium diet, if we give to our patient ACE inhibitors or sartans, if we give to our patient SGLT2 inhibitors, then we are covering the whole glomerulus in order to reduce the rate of decline in kidney function. So there are several pathways to interfere with intraglomerular pressure and consequently with the rate of decline in kidney function. Now, there is this idea of protein restriction, but in the past years, there are several data to suggest that not only the amount of protein intake is important, but also the type of protein that we use is also important in preventing diabetic kidney disease and the chronic kidney disease in general. And here is a study coming from very recently from our colleagues in Taiwan on a large sample size. And they compare with in patients with diabetes, and the patients with diabetes with a very good GFR, if we look here. And what they found, they compared patients on vegan diet with those on lacto-ovo-vegetarians and patients with a mixed diet. And what they found that one can see here in the table to the right, they found that the lacto-ovo-vegetarian and the vegan diets were associated with a lower risk of diabetic kidney disease. And this type of diets, again, vegetarian plus lacto-ovo and vegan diets, even lowered the risk of diabetic kidney disease related to a high BMI and to hyperuricemia. What about the possibility to postpone dialysis initiation? And here we are coming with an experience of our group. from a single center prospective interventional trial in diabetic kidney disease patients with GFR below 30 mL per minute and with high proteinuria, higher than 1 gram per gram urinary creatinine. And this study had 3 phases. It was, of course, the pre-enrollment phase, then a running phase of 3 months, during which we have recommended to these patients a low protein diet, 0.6 gram per kilo per day. And during this phase, we have assessed the compliance, the adherence of our patient to the diet. And then there is the intervention period of 1 year, 12 months, during which we administered low protein diet plus keto analogs, 1 capsule for each 10 kilos of ideal body weight per day. And our results were excellent. Proteinuria decreased from 5.2 to 1.6. Actually, it was a 7% reduction in proteinuria during a 1 year period. Then, looking at the kidney function, here in the first line, we are looking at the historical GFR decline. So the GFR, the trend in GFR before enrollment. Our patients used to lose 6 mL per minute per year. Then here is the running phase. And then during the intervention period, one can see that our patients experience a mean decline in GFR of 1.3 mL per minute per year. In other words, the rate of decline in kidney function during the intervention period was almost 5 times slower than before the enrollment, than the historical data. There are also benefits related to the blood pressure control. And here we have the red line is depicting the median. And one can see that by the end of the study, the median in blood pressure, in the mean blood pressure is depicted here. It was a reduction of almost 11 millimeters of mercury, just as a consequence of the low protein diet. We found also good trends for metabolic disturbances, for the nutritional status, and for the inflammation. We found a significant increase in serum albumin, significant decrease in serum level of C-reactive protein. The metabolic control have been improved. The body mass index significantly decreased. So to summarize the data that we found in our trial, it is probably important to say that a supplemented low protein diet allowed for a better blood pressure control, allowed for a better metabolic control of diabetes, allowed for significant reduction in proteinuria by 3.5 gram per gram per year and for 1 year, and a significant reduction in the rate of decline in kidney function. And it is impressive, in my opinion, to see this line, the gray line, which is depicting the actual trend in GFR, as compared with the red line, which is the expected trend in GFR in case it was, in case the historical data have been extended. And one can see that it was expected that after 10 months, all the patients to start kidney replacement therapy. And what actually happened is that no one needed kidney replacement therapy, and the rate of decline was much slower, again, 5 times slower. Now, other indication for keto supplemented low protein diets. There are also other indication and perspectives. There are also some data in hemodialysis, but the most relevant data, in my opinion, are related to the peritoneal dialysis. And here is a study coming from, originally coming from China, and they compared low protein diet with keto supplemented low protein diet and with a group with high protein. And one can see here that in the group with keto supplemented low protein diet, this one in black quartiles, the GFR was significantly higher in patient taking SLPD as compared with those on low protein diet and with those on high protein diet. And if we look at the residual kidney function in, again, in PD patient, one can see that the urinary output is much higher, remained much higher on long term in the supplemented low protein diet group as compared with only low protein diet and with high protein diet. In other words, a diet with 0.6 to 0.8 gram per kilo per day is safe in PD patient when combined with keto analogs and is associated with an improved preservation of residual renal function in this PD patient, of course, without significant malnutrition or inflammation. As for hemodialysis, there are some old data, old I mean coming from 1980s something, coming mainly from Czech Republic, and there is some experience from Professor Teplan showing the possibility to reduce inflammation in patients on hemodialysis and to improve the nutritional status with keto analog supplementation. The data that I find very interesting and very up to date, I would say, are related to the incremental dialysis. So we are discussing about the onset of kidney replacement therapy, not with the usual 3 times weekly schedule, but just with once weekly dialysis and low protein diet for the other, supplemented, of course, low protein diet for the other days, or two dialysis session a week, plus the keto supplemented low protein diet for the rest of the days. And the main experience is coming like for the dietary intervention in general from the Italian groups. And here is the Italian group of Professor Adamasco Cupisti from Pisa. And here is the experience with once weekly dialysis plus keto supplemented low protein diet for the other days. And one can see that in patients not reaching the cutoff value of urea clearance by dialysis and nutritional intervention, the incremental dialysis that does not make sense. But on the other hand, in patients reaching the desired urea clearance of 3 mL per minute, there is no significant difference in dialysis efficacy when we compare incremental dialysis, again, once a week plus keto supplemented LPD for the other days, and the conventional hemodialysis session. And if we look again at the residual renal function in a large sample size, again, it seems that incremental dialysis allows for a much better preservation of residual renal function as compared to the conventional thrice weekly schedule. So an integrated diet hemodialysis regimen once or twice weekly may represent, with only once or twice weekly hemodialysis session, may represent a provocative paradigm shift for many practicing nephrologists and dialysis providers, and may become the ultimate model for precision medicine in kidney failure, especially for especially for a certain category of people, like for the elderly, for example. And this is a very interesting review in CJSON by Mariana Mura. And the reason I put here this reference is, of course, it's interesting and it's relevant for the discussion that we have, but I have to admit that I put it because it's here the name of Professor Kalantar Zadeh, which is a personality very much related to this field of nutrition and dietary intervention, and because his colleague Mariana Mura is Romanian. He is of Romanian origin, but she is working with Cam Kalantar in Los Angeles. So to conclude, the low protein diet supplemented with keto analogs seems to be effective and safe in preventing diabetic kidney disease in patients with diabetes mellitus, especially the vegetarian and vegan diet, and in postponing kidney replacement therapy in patients with advanced diabetic kidney disease. Now, the vegan and vegetarian diets seem to have advantages versus mixed low-protein diets. The keto supplemented low-protein diet, in our experience in diabetic kidney disease, was associated with a 70% reduction in proteinuria, with a better blood pressure control, and with 5 times reduction in the rate of decline in kidney function. As for the other indication of keto supplemented low protein diets, we could definitely consider the hemodialysis, mainly for this approach of transition to dialysis, of incremental dialysis, and for the peritoneal dialysis, mainly to preserve the residual kidney function. And this is, you all know, my favorite slide with diet as a Cinderella dominated by making her job actually, dominated by her stepmother, dialysis, and the stepsister, kidney transplantation and ACE inhibitors. And currently we have to add also the SGLT2 inhibitors. But I hope that after the relatively recently released KDOKI guidelines for nutrition of the update of 2020, I think that I have to replace this picture with Cinderella and to replace it with this flower and to consider diet as a part of an integrated approach in the conservative management of chronic kidney disease. And we have considered ourselves nephrologists, but also diabetologists, cardiologists, psychologists, dietitians, etc. All the people involved in the kidney care, we have to be the petal, like the petals of this flower working together. And as the final message, again, congratulations everybody for the World Kidney Day. This is the message of last year, living well with kidney disease, diet included, and the message for this week to try to find kidney health for all, to bridge the knowledge gap to better kidney care. Thank you very much. Thanks for the invitation and for your attention and for your interest in the conservative management of chronic kidney disease.
So yes, ma'am, it's quite interesting, and as usual, with your spirit of experience, a lot of newer approaches you have given for today's program. So before going into the clinical discussions by Dr. Carmen, ma'am, I would like to share a few small information about. So we are in today's topic, probably for the new people who have joined in. We are in the dietary interventions in preventing diabetic kidney disease and postponing kidney replacement therapy. And the speaker is Dr. Liliana Garneata from Romania, the international researcher in renal nutrition. And we have eminent speakers and moderators in this session. And to talk about Fourrts. Fourrts is in the pharma industry for the past 45 years, following the motto of innovating for good health. We are the pioneer and the leader in nephro protection in India with brands like Nephrosave for microalbuminuria, Nephrosave Fort for macroalbuminuria and creatinemia, Nephrosave Keto to delay dialysis in advanced CKD, and Sodisave in metabolic acidosis. Moreover, our keto alpha analog brand Nephrosave Keto is the most affordable brand in the market. It is available as both tablet as well as sachet. With this, I hand over the session to Dr. Carmen for the further discussion of her about the clinical discussions about keto alpha analogs. Thank you. Over to you.
Thank you very much.
Very interesting talk, Dr. Garneata, especially the topic on incremental dialysis. We've been talking about it in peritoneal dialysis, quite a bit, with preserving kidney function and peritoneal dialysis. We have this approach of incremental dialysis. And, it's an interesting approach that has a lot of pros and cons, with hemodialysis. And, we'll have to wait and see. And a lot of exciting research in this
Yes, that is why I have mentioned that it is particularly important for a certain category of.
Right.
It's probably not for everyone. I mean, everything has to be individualized when we talk about all approaches, not only in nephrology, in medicine in general. That's nothing good for everybody. But certainly, at least for elderly people, it would be interesting to have this type of incremental approach. And maybe also for the young people who are waiting for kidney transplantation. I don't know how things are going on with this in India, but in Romania, for example, the waiting list for kidney transplantation is very long, and people wait for a long period of times for a kidney graft. And that is why preserving kidney function is very, very important for them. And also preserving, how would you say, the freedom. I mean, they are related to the machine just once a week or twice a week. It's something different. So for certain category of people, and even Adamasco Cupisti that I have cited here, but that there are also other centers in Italy looking to this type of incremental dialysis. They all agree that's not for everybody, but definitely is working, and it's important for certain people.
Great.
So regarding, before Professor Carmen starts, just some comments regarding this concept of incremental dialysis. I think we all gone through the beautiful paper by Professor Carmen-Antonia regarding this. And there is a story before this paper was published. In 2014, Kalantar came here in India and he visited our center. And unfortunately, in US, the Davila system, it is mandatory that everybody has to go through the 3 per week dialysis. And in our country, because of the resource constraint, a lot of patients who otherwise had a very good renal output, even a preservation output, good, better nutritional status, we do manage a lot of patients with once in a week, once in a 10 days dialysis. So Kalantar was very moved with seeing some patients, and we contributed in the study in about 35 patients' journey, that how this patient could be taken care of, and then the component of incremental dialysis came up. So it is really a practice in India. A lot of centers, you will find the patients are there in once per week dialysis, and they are doing fairly well. And as Professor Garneata rightly mentioned, this is not applicable for everyone. It has to be individualized based on the residual renal function, nutritional status, and other metabolic comorbidities. And I strongly believe not all shoes fit for everyone. There are a lot of patients are there that doesn't require 3 per week dialysis. That does very well with even 1 or 2 dialysis in a week. So over to Professor Carmen. We are here to listen from you. Please go ahead. And I think at the end, we'll have a discussion regarding all the topics, whatever we have discussed here.
We also performed incremental dialysis years ago when there were not enough facilities for hemodialysis, and I think this is also the situation in India, and we were forced to do that. We didn't think of incremental dialysis, but we were not able to put everybody on 3 times a week, so we used once a week or twice a week, and I have to admit that the survival was very, very good at that time.
Absolutely.
Of course, one can argue, and that is why I didn't present this data. One could argue that we have dialyzed at that time young people and people without comorbidities. I have to share with you that it was a selection process where the times, it is already history, but it was in 1990s. It was not 100 years ago. And this experience that we have with sort of incremental dialysis was actually good.
So the point is, even for the young also, I mean, if you had the option for putting them on machine once in a week, nothing wrong, because it saves the resource, and also it has not a very negative impact in terms of morbidity and morbidity, has been evidenced by a lot of studies now coming up on incremental dialysis. That's it.
Yes.
Okay, good evening again. For today, I will present the sub-analysis from a study performed in our clinic about the safety and about the efficacy in the elderly population with advanced diabetic kidney disease with supplemented low-protein diets. Next slide, please. So, like Dr. Garneata previously explained, low-protein diet seems to be very important in slowing the progression to CKD, mostly if it is associated with a low-sodium diet and also with renin-angiotensin-aldosterone inhibitors. Next slide. And in this case, some studies showed that this type of intervention can improve the metabolic disturbances in advanced CKD by improving the nitrogen balance, by improving the calcium and phosphate homeostasis, and also by improving the metabolic acidosis. And it can also improve the insulin resistance, and it can also reduce proteinuria, and it can also optimize the blood pressure control. So in this idea, it can postpone kidney replacement therapy by improving the metabolic control and by decreasing the decline of kidney function. And it can also have a positive effect on the quality of life. Next slide. Some studies showed that this type of nutritional intervention can also have some adverse reaction, and we're talking about the risk of malnutrition, and we can also talk about the difficulty to apply this type of nutritional intervention because of the poor compliance to protein restriction and because of the needing of closely monitoring those type of patients. In this area, we can discuss about using and needing a multidisciplinary team to monitor these patients. Next slide. Another aspect is that in elderly patients, the safety is a more important concern than in non-elderly patients, but there are some studies that showed that both supplemented very low protein diets and low protein diets themselves can be effective and can be safe in postponing dialysis treatment in elderly patients without diabetes. But the great idea is, and the great question is, if we can use this type of nutritional intervention for patients, for elderly patients that also have diabetic kidney disease. So not only chronic kidney disease, but also diabetes mellitus. Next slide. And in this respect, I want to present unpublished data referring of sub-analysis that is focusing on the safety and on the efficacy in elderly patients. Next slide. So we included adult patients with the diagnostic of diabetic mellitus stage 4 plus CKD, with a protein to creatinine ratio more than 3 grams per gram urinary creatinine, and with a good nutritional status. So the scoring in subjective global assessment was A, and the serum levels of albumin were more than 3.5 grams per deciliter. We excluded patients with previously rapid decline in GFR, so more than 10 milliliters per minute per year. We excluded the patients with uncontrolled blood pressure and with active kidney disease with indication of specific therapy. And we also excluded patients with severe comorbidities. So the study was unicenter, was a prospective study. The total duration of the follow-up was about 50 months with 3 months running period and 12 months of intervention. And from 452 potential subjects, only 92 completed only 97 were enrolled in the study, and 92 completed the study. So the intervention was a low protein diet, about 0.6 grams per kilogram per day, was mainly vegetarian, supplemented with keto analogs of essential amino acids, one tablet per 10 kilos dry body weight, divided in 3 doses. The primary outcome was the variation in proteinuria from baseline to the end of study. And the secondary outcomes were the safety parameters at the end of study, like the subjective global assessment, like body mass index, like serum albumin, and like C-reactive protein. Next slide. So we compared the results from non-elderly patients to elderly patients, and we see that the body mass index and the scoring of subjective global assessment, also the levels of C-reactive protein and the albumin were constantly the same in both groups. And the protein intake at inclusion and at baseline and in the end of study were also the same in both groups. Next slide. So of the total group, 42% of the patients were elderly, so more than 65 years old. And 21% were late elderly, so more than 75 years old. The median age was 75 years old from the elderly group. 64% were males. And as we can see, the proteinuria and the GFR decreased very, very, very much during the study. But I will come over the GFR a little bit later. I want just to say that the body mass index also decreases from the baseline, and the percent of the overweight patients decreased from 76.9 to 56.4 at the end of the study. And we can see that there were differences also regarding the C-reactive protein levels. So only 75% of the patients had inflammation at the end of the study. Next slide, please. Regarding the GFR, I've told you that it was a statistical decreasing of the GFR regarding the screening GFR to the end of the study GFR, but it's not that important because we can see the median slope, so we can see the median decline of the GFR. That is more important, and we can see that before the inclusion, the median decline of the GFR was around 0.5 milliliters per minute per month. And after the baseline, so at the end of the study, the median decline of the GFR was around 0.5. So it also decreased 5 times in the elderly patients compared to non-elderly patients. Next slide. As I previously discussed, proteinuria had also a spectacular decrease. So it decreased from 5.14 grams per gram urine creatinine to 1.5 grams per gram urine creatinine. So around 70% of reduction from baseline to 12 months was registered also in elderly patients. In a binary regression analysis, lower levels of inflammation, so lower levels of C-reactive protein, were associated with the compliance of the protein intake, with lower proteinuria, and also with high levels of albumin. So the compliance to the protein intake seems to be linked to a lower inflammation in those patients. Next slide. So in conclusion, in elderly patients with advanced diabetic kidney disease, low protein diet supplemented with chemoanalogues of essential amino acids seems to be effective in reducing the decline in GFR and in proteinuria, while being also nutritionally safe. Next slide. But again, there are some limitations, and one of them seems to be both the compliance of the patients to such type of nutritional intervention, and assessing and explaining the nutritional intervention. And as I previously said in the presentation, patients used only the food diary technique to be able to be evaluated. And from our clinical experience, only 21% of the potential subjects were able to respect the indications. So maybe if we can improve the compliance by developing an interactive digital platform, the results could be more promising. And in this respect, we have developed an interactive digital platform to monitor and to also dietary counseling the patient's compliance. Next slide. So the idea was to assess both the effects of low protein diets in improving the metabolic disturbances in CKD, and also probably postponing the kidney replacement therapy, But we want also to assess the role of an application or of a digital platform to increase the patient's compliance with at least 20% by using an interactive platform. So the patient should use this application daily, so will be more effective than the 3-day food diary. And the patient will also have the possibility to assess the quantity of the food depending on the portion or depending of the weight. So I am hoping that in the near future we will present the results of this new potential study. Thank you very much for your attention, and I finished the presentation. Thank you.
Thank you, Cameron, for your beautiful presentations. However, it is unpublished data, but there's a lot of insight to look in terms of preventing diabetic kidney disease. And lastly, we all, those who have involved in dietary nutritional research, we know how it is difficult to assess compliance, because nutrition is such a subjective thing. Whatever you prescribe and what patient is exactly consuming, there is a huge gap. So keeping that in mind, I have a question to Professor Liliana Garneata and also Cameron to you. How did you monitor the protein intake? Did you did the nitrogen balance study, or you did the NPCR? And how did you monitor the protein intake for a long period of time, over a period of 1 year? That was the biggest challenge in all these nutritional studies, to see whether there is any compliance or the deviation from the original protocol is happening or not.
Yes, it is indeed difficult. We have used the 3 days food diary, and we use it mainly for the energy intake. And also for the protein intake. But for the protein intake, we have particularly used the urinary urea expression in a 24-hour urine collection, and we have used then Marley's formula to estimate the protein intake. Actually, we have now in our department, we have a calorimeter, and we intended to prescribe the diet and also to assess the compliance to the protein, to the energy intake at least, using this calorimeter. But unfortunately, pandemic started immediately after we got this calorimeter, so we didn't start so far. So we are still using the 3 days food diary and the urinary urea collection. And this idea of developing the application is Carmen's idea, and she's following this for her PhD approach. So I hope to come with this data. I don't know, maybe the next year Carmen has to tell us. I don't know. I'm just supporting her.
Okay. So in this regard, because we have developed a tool for potassium monitoring as a digital device, as you say. And in extension, we are now developing a phosphorus and the protein monitoring tools. Okay. So obviously, as Cameron said, that the digital data entry is much easier from the patient perspective, and also it is very easier to track from the researcher perspective also to what exactly happening. And so we have already developed the potassium tool. I can show you, if you can. This is a very interesting and very nice tool. Anybody across the globe can use it, but they can. Obviously, it has a all Indian diet as a priority. I don't know what you people eat in Romania, but majority of the food which is available in India, from the National Institute of Nutrition, we have a very beautiful database of the different food portion and the potassium content. And the same database also we had a protein, carbohydrates, and the phosphate contents. And so we can calculate based on how much someone is taking, and the app automatically gives us the entire potassium intake, protein intake, calorie intake. Now the challenge, that's good. But the challenge we are facing is the quantity standardization. You know what happens, So what is 50 gram for me at my clinic and what is 50 gram for the person at home, even you give the measured bowls and all these things.
Yeah, of course.
It happens somehow. So we are trying to solve it in a very different angle. So one of our very interesting chemical scientists who has designed a camera, that camera app has a 3D volume measurement thing. So if you take a snap, it will give us an idea of the volume. Okay, so that we are trying to develop, hopefully maybe another 2 months.
That's excellent. I have seen something like that. I mean, I have heard about that in Thailand, and I'm sure it's working in Thailand.
I'll send you, ma'am. I'll send you the link. You can have a try. It's a very
please. It's excellent. It's excellent idea, and of course we can follow this. I have been impressed by the experience they have in nutrition in Asian countries, and the idea was to develop a collaboration, and even somebody from our group to go to Thailand or some other parts in Asia where they have a huge experience in that area. But again, we stopped this idea with pandemics. But indeed, there is a lot of experience there, and there are a lot of tools, and there are trained dietitians there. I have met dietitians in India as well. And this is not happening in Romania, unfortunately.
So another method we do practice in our clinics and also in our research that we have seen, if you have a repository of the food models, all the different foods what someone can consume, if you make a model of that in different proportion and portion size, that makes very easy understanding for the patients. So
yes.
So that's another way we do use in our clinics. So it has a significant impact. Whatever you write in paper and whatever you show through a model, that is a totally different understanding from the patient perspective.
I fully agree. There is a need for tool and for this kind of tools, and we are understanding every day more and more this necessity. Yes, we have to follow also this.
So I have some direct clinical questions to you, ma'am. I think we are not getting any questions from all the participants.
There is a question, I think. There is a question.
One question.
Dr. Singh. Dr. Singh is asking what foods should be avoided.
It's a very, very broad question. Let me answer. This is from the Indian perspective. The question is...
Yes, that's true. Yeah.
Yes, from the general practitioners, I believe Dr. Singh might be practicing general medicine, because those who are practicing in nephrology, at least we are very careful and cautious about the nutritional regime what a patient should follow. So regarding what food should be avoided, instead, it is better not to mention what to be avoided, rather what to be taken. Because the moment you utter in front of a patient that you can't take this, they goes in a very, very depressive mode. Instead, if you open the plate in that way, that these are the options you can take, these are the options you can't limit in your diet, that gives much more positive things. And it's a very, very vast question, Dr. Singh, because for CKD, especially for diabetic kidney disease, when we plan nutrition, we have to look at multiple aspects in terms of patients' nutritional status, their biochemical abnormality, metabolic parameters, and then we come to the conclusion what should be the right nutritional regime for that person. So I think Professor Liliana Garneata, you also agree that it cannot be a one-sentence answer what need to be avoided. Instead, they can take a lot of things in a moderate amount under the supervision of a renal nutritionist. That should be the best idea to look at this question. There was no more questions, I believe. I think this question was to...
As far as I see here,
yes. No. So we have another beautiful paper regarding BLPD and ketanol supplementation from India by Dr. Suratkar. I hope there was 45 to 50 patients was included in the study. And it was obviously for the retarding the need of renal replacement therapy and also retarding the progression of diabetic kidney disease. So in that study, they had a very interesting observation that those who are in BLPD, the erythropoietin requirement was also less. So that was a very interesting observation. So I want to understand from you, do you look at this area, someone who is prescribed for SBLPD as per your study regime, what was the impact on erythropoietin requirements? Is there any betterment in the erythropoietin resistance in those groups or the need of erythropoietin for managing hemoglobin? To Professor Liliana.
Is it a question because I was not able to hear?
So I was asking whether the SBLPD or BLPD supplemented by ketanol, did you observe any response in terms of need of erythropoietin?
You mean that anemia could be aggravated by this SLPD? In our observation, it was not. In our data, and I'm not talking just about clinical trials. I'm talking also about our daily clinical practice. That we didn't notice any change, neither in the hemoglobin level nor in the iron status. Okay. But on the other hand, that's true that at least in patients who are on a vegetarian diet or mostly vegetarian diet, the lack of meat in the food, which is actually the problem for our diet, for local diet, could be related to the iron deficiency.
So that's great. Another.
What do you say, Dr.
Pratim sir? Can we conclude?
I was. Yes, we can conclude because already it is 5:15.
Yeah.
But before we end, it was a very enlightening discussion from both Cameron and Professor Garneata is not there right now. So it was a very, very precise, to the point, and also a lot of new information, especially in the incremental dialysis aspect, has been discussed here. So we are really enlightened. I believe all the participants in this beautiful webinar, they all got the real insight about the practice and all the research data for that. And there is one small announcement for Nagasankar and Gayatri that the Nephrocare study, what we did, the randomized control trial, that got accepted with the JAVI. We just got the message a few days back. However, it is not for the diabetic patients. We did with the non-diabetic CKD patients, but it has been accepted. I hope it will be very soon published. Cameron, for your information, we did a similar study with not with the ketanol, we did with the acetylcysteine and taurine replacement to retarding the progression of the CKD. And in this study, we did not include diabetes. Henceforth, I did not told about it. This study got recently published. Recently accepted. It will be published very soon. Okay. So that's it.
Okay.
Excellent, sir. Excellent.
Awesome. Thank you so much, Dr. Gupta.
Thank you.
Your insights have been very You have been amazing, because like you spoke about like, incremental dialysis in India, because in the US, we're restricted because we have Davila and the large LDOs, going through it. It's an interesting topic. And thank you very much, Dr. Carmen, and please convey our regards to Dr. Garneata as well. And thank you very much, Dr. Gupta, for your time and enlightening discussion. And for all the participants, thank you very much for spending time with us. We want to bring, we want to connect a lot of doctors. We're doing a lot of exciting research in the field of nephrology. And thank you for your participation. And we'll see you soon in the next webinar. Thank you.
Thank you.
Thank
Bye.
you. Thank you.
Thank you.